First of all, thank you for coming. We are honored to host Professor Kurland today, and also Yasemin will lead the session. But before that, I would, on behalf of the Turkish Pediatric Pulmonology Society, I would like to thank him, and also I would like to forward our condolences to his wife, because unfortunately she had lost her mom yesterday, and we are very sorry, and we wish the best. And also thank for all the participants from all around the world. I'm sure that we'll have a great lecture, and I will now just forward the microphone to Yasemin.
Thank you. First of all, I would like to start with we are very thank you for accepting our invitation. And I think he doesn't need any introduction, but I will talk briefly. Geoffrey Kurland is a pediatric professor at the University of Pittsburgh, and he's the director of pediatric lung transplantation program. He has unique expertise in pediatric flexible bronchoscopy, pediatric lung transplantation, and also in childhood lung disease. He has authored many articles and book chapters, and he has also written a book describing his own experience as a patient with leukemia, and he's also a long-distance runner. And I am so grateful that I had spent 4 months working and observing with him, and he's a great mentor. And please, Geoffrey.
Well, thank you for that invitation. Can everybody hear me? I'm going to share my screen. I only wish, that I could be with you personally, which there in Turkey, to be honest. Because wait a minute, one little thing I want to do. Hold it. Let me just change. Let me change one thing before I do that. I'm going to stop my video there. Okay. You don't need to see me. Okay. So I really wish I were there in Turkey, which I visited on my during my 70th birthday. I'm a little bit older than that now, but that was one of the great experiences of my professional life, was being able to visit my friends in Istanbul and Antalya, then in back well, not so many, well, enough years ago. I'm going to try and give a talk here today about bronchiolitis obliterans in children, the definition, diagnosis, and treatment. As you can see, I've recently revised the slides, and I almost revised them more this morning when I heard a wonderful lecture by one of our immunologists here, and I'll allude to that. I'll mention that a little bit later in the talk briefly. I wasn't able to grab some of those slides because they would have fit into this talk quite nicely. Let me see if I can advance the slides here. Okay, I have a few disclosures. First of all, I'm a consultant to a company called Triple Endoscopy, which has no connection at all with this talk. I'm a clinician. I'm not a molecular biologist. I have no NIH support. I don't have a lab. Sorry. And it's hard to give a single talk covering everything about bronchiolitis obliterans. I'm going to mainly talk about post-infectious bronchiolitis obliterans. I'll mention bronchiolitis obliterans that follows, say, lung transplantation, and very limitedly about that following hematopoietic stem cell transplant. But a lot of what I'm going to talk about is post-infectious, because whenever I talk about this subject, the questions I get afterwards usually have to do with post-infectious bronchiolitis obliterans or PIBO, because that's what we as pulmonologists, I think most of us see. We're not all doing lung transplantation. I mean, I see enough of that, but so that's what this is going to concentrate on. A lot of people have helped me in my own understanding of this topic. Robin Dieterding, Alicia Casey at Harvard, who's a close friend, and Coloma Teper in BA, and I didn't put his name on here, but Claudio Castaños, who's on this talk, who's in the audience, also knows and has written on this subject. I also have to thank the Stiftung Stark Lung Foundation in Germany, for their support over the years. I don't get any money from them, but I've been to several of their conferences, and some of these slides come from those talks. I'm going to, wait a minute, everybody's, there we go. I'm quoting Sir William Harvey. Nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows tracings of her workings apart from the beaten paths. Nor is there any better way to advance the proper practice of medicine than to give our minds to the discovery of the usual law of nature by careful investigation of cases of rarer forms of disease. And post-infectious bronchiolitis obliterans and bronchiolitis obliterans in general are unusual and fairly rare. And by understanding how they come about, we can learn a lot about how the lung is formed, how it responds to infections or other insults, and how it repairs itself. So let's talk a little bit briefly about what is bronchiolitis obliterans or obliterative bronchiolitis. Depends on where you're from. It's relatively rare, but it's important to recognize because you need to recognize it because of what it masks or mimics. It's a complication of lower respiratory tract epithelial injury. This leads to subepithelial inflammation and fibrosis, which in turn leads to narrowing or complete obstruction of the smaller airways. These are the respiratory and terminal bronchioles. Airway lesions, however, are not uniform, and skip lesions are common. That is, the entirety of an airway will not be identically affected in the case of bronchiolitis obliterans. And bronchiolitis obliterans actually may be a misnomer because not all the airways are always obliterated. So this makes this, having this non-uniform distribution, makes it very difficult to diagnose with simple transbronchial biopsies, which are done following, say, lung transplantation. But as I'll talk later, that's not an easy way to make the diagnosis of bronchiolitis obliterans. These lesions lead to fixed airway obstruction. There are variable causes and outcomes from bronchiolitis obliterans. For example, it's very common following lung transplantation. If you wait 5 years or so after a lung transplant in those survivors, about 50%, at least in the pediatric literature, will have evidence of bronchiolitis obliterans. It's much less common following hematopoietic stem cell transplant, but it's still a fairly good, number. And it's distinctly uncommon following most viral respiratory infections. The problem is the prevalence is driven by the high number of viral respiratory infections, which are extraordinarily common. So we wind up having a fairly high number of cases, even though the individual risk for any one patient with a single viral illness is very low. So PIBO, or post-infectious bronchiolitis obliterans, thus becomes relatively common because of this. The exact incidence is unknown. And finally, it's most often, or not often, but it's often misdiagnosed or missed, delaying its recognition and potential treatment. I will underline the word potential treatment. This is a nice article about obliterative bronchiolitis by Barker and his colleagues, published in the New England Journal in 2014. It has 8 pages, it has 60 references, and it has sections on pathogenesis, clinical detection and monitoring, mainly looking at pulmonary function testing and imaging techniques. And it also talks about the associated conditions that can lead to obliterative bronchiolitis, including autoimmune disorders, exposure to inhalational toxins, post-stem cell transplant and post-lung transplant, and a section on post-infectious. That section on post-infectious bronchiolitis obliterans totals 3 sentences in this entire article, and only 2 of the references are related directly to this feature. It also talks about the treatment, mainly, the treatment and the outcome, which is highly variable. Let me see if I can move. Okay, good. And that only comprises 1/2 of a page. And there really, as you will see, there isn't a lot of really good data on good treatments for this entity. But it has some great photographs and pictures. This is a normal bronchiole on the left here. You can see a very fine epithelial surface. You can actually see the cilia here if you look really carefully. The subepithelial region is very narrow, very thin, and you can see some smooth muscle. This on the right is an obliterated, almost nearly obliterated bronchiole. You can see the lumen is markedly constricted. And one of the other names for obliterative bronchiolitis is constrictive bronchiolitis because of that. You can see the remnants of the smooth muscle in the wall. And this is a fibromyxoid layer of dense scar tissue, if you will, or fibrotic tissue with a cellular infiltrate here. Here's an accompanying artery here. Arteriole is over here on both of these pictures. Well, is bronchiolitis the counterproductive or overzealous repair of airway damage? I would offer that it is. Here's a nice diagram from Talmadge King's chapter on bronchiolitis in an earlier edition of Fishman's Pulmonary Diseases. It starts with an infection or other insult to the airway epithelium here at the top, leading to injury or flat out destruction of the airway epithelium, leading to acute and chronic inflammation. And most of the time, this repairs completely to healing. But in those rare occasions when other factors are involved, and we'll talk about those, it's repaired by proliferation of granulation tissue, leading to fibrosis of the airway wall and lumen, and ultimately obliteration of that lumen in extreme cases. Now, the repair to healing is governed by certain cytokines and growth factors that we're still learning about, I have to say, and also cells that are involved with that. I didn't put that on this slide, but those cellular factors are also important. Likewise, they're making the repaired by proliferation of granulation tissue is under the influence of cytokines, growth factors, and MMPs or matrix metalloproteinases. And there are also cell types, including neutrophils, lymphocytes, and ultimately myofibroblasts that lead to this fibrosis and cellular infiltrate in the airway wall. Now, this is all nice looking here, but it doesn't give us a lot of specifics. And the next slide is proposed pathogenesis by you in the Korean Journal of Pediatrics, but this is now 6 years old. But it's relatively straightforward, and I think it understates the actual events because we've learned a lot in the past 10 years on what goes on in the airway, but I didn't have a slide to put in here, but I'll summarize it briefly. There's an epithelial injury with usually a lower respiratory tract infection, sometimes mycoplasma instead of a virus, but it's very commonly virus, and you'll see which ones in the near future. This leads to a release of pro-inflammatory cytokines from the cells here, the epithelial cells, but I also have to say that in the airway wall are other cell types, including immunomodulatory cells, which is not pictured here. With the release of this, these cytokines are an influx of neutrophils, ultimately an activation of matrix metalloproteinases and other mediators. Further cells are either there already or called in, CD8 T cells and Th17 cells, with other cytokines being released. There's matrix degradation and collagen deposition, fibroblast transformation into myofibroblasts, smooth muscle hyperplasia, and this all requires neovascularization to support this fibrous tissue development. This leads ultimately to the narrowing and sometimes obliteration of the lumen over here because of the increased thickness of the wall here. This is all looks relatively straightforward and nice. I think it is much more complicated than it's presented here. And if you ask me to give this talk in another couple years, I may be able to outline what some of those changes might be, I hope. But a lot of people are working on that at this time. How do these patients present clinically? Well, the symptoms they have are nonspecific. They have tachypnea, they have wheezing, they have retraction sometimes, they fail to thrive. And if they're older, they have dyspnea and exertion. The signs also are nonspecific. On auscultation, one can hear wheezes, crackle, and prolonged expiratory phase in many patients. Sometimes, though, the airflow is so low that the lungs don't have any of these features, which require a lot of airflow. Hypoxemia with exercise or intercurrent illnesses is also often seen. But the laboratory findings are important. Pulmonary function testing shows airflow obstruction, a lack of bronchodilator response, and if one does the measurement of lung volumes, you see normal or increased total lung capacity and air trapping with an increased residual volume to total lung capacity ratio. Chest radiographs may show hyperinflation and sometimes increased interstitial markings, but are all too often relatively normal, except for the hyperinflation. But a high resolution CT scan of the chest with the ventilation held at total lung capacity and FRC can show what's called mosaic perfusion or mosaic attenuation, if you will, with some areas that are more and some areas that are less dense because of relative hyperinflation of those that are more blacker, if you will. And also you can see sometimes central bronchiectasis. We should remember that the respiratory and terminal bronchioles are, if you will, the bridges between the alveolus and acinus and the larger airways. And having a disease, thinking of a disease such as bronchiolitis obliterans being confined only to specific airway size, I think is misleading because these patients can go on to develop more central bronchiectasis because of damage to the lower airways. The history, I believe, is very, very important in these patients because there are multiple factors that can lead to bronchiolitis obliterans in its development. Some of these are listed here. I've highlighted in red the adenovirus, especially serotypes 3, 7, and 21, and possibly 5, as well as post-lung and post-hematopoietic stem cell transplantation. But as you can see, this is a very large list of entities that have been associated with bronchiolitis obliterans. Now, having said that, I want to put one little note. I put a question mark after respiratory syncytial virus. And there's and when I first presented a talk on bronchiolitis obliterans probably 15 or 20 years ago, I mentioned RSV as being one of those possible viral associations. And many in the audience, and this was at ATS, so there was a lot of people yelling at, well, not yelling at me, but pointing out that there are so many cases of RSV, and yet we see very, 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 very few of them go on to develop, if any, go on to develop bronchiolitis obliterans. And I think that's probably true. Most of the cases that I've seen with RSV have also had a co-infection with another virus. So if someone has RSV and is really, really sick, look for another virus, particularly adenovirus. How do we identify those who are at risk for the development of post-infectious bronchiolitis obliterans? Well, a previous history of the viral infection, obviously, usually in infancy, and especially with adenovirus. With infection, however, it's not just the infection, it's severity that's key. Most of these patients have a need for respiratory failure or a need for mechanical ventilation. Most of them have a prolonged hospital stay, and I'll show you some data to show this. In limited studies, there are increased serum cytokines that are associated with more severe cases of adenoviral bronchiolitis or pneumonia. I've highlighted those here, and I'll show you another slide of this in a few minutes, or less than a few minutes, actually. Getting back just briefly to lung transplantation, it's felt that bronchiolitis obliterans syndrome, that's the S here, this may be, following lung transplantation, may be an IL-17 dependent autoimmune phenomenon that is directed at normally hidden antigens. One of those is collagen 5, the other is kappa alpha tubulin 1 or kappa alpha 1 tubulin. There may be a possible role for this in post-infectious bronchiolitis obliterans. I believe that's probably likely, but I don't think it's been definitively proven. This is a retrospective study by Murtaugh in 2009. They studied 415 children, all of whom had a lower respiratory tract infection caused by adenovirus. Notice the years that this span is a long retrospective study, and they divided those into those who recovered, those who had sequelae, usually chronic oxygenation and/or bronchiolitis obliterans, and those who succumbed and died of the infection. Notice that the days of hospitalization are especially long in those who had sequelae or probably BO. Many more had mechanical ventilation, and many more had adenovirus type 7, serotype 7, as just some of those factors. And the odds ratio for those who had greater than 30 days hospitalization of having those risk factors of developing BO was 24.5. And so that's a very strong indicator of those patients who are at risk for subsequently being diagnosed with post-infectious bronchiolitis obliterans, those who have long hospital stays. Likewise, it's not just adenovirus, it's adenovirus and mechanical ventilation are especially seen as risk factors for BO in patients with bronchiolitis obliterans. Adenovirus alone carries an odds ratio of 49. Mechanical ventilation, an odds ratio of 11 for the development of post-infectious bronchiolitis obliterans. This was a retrospective study of 109 patients who had known bronchiolitis obliterans. As you can see, the vast majority of them had a previous adenoviral infection. A limited study of patients with, this is a small study of 38 patients who were all infants, all of, quote, low socioeconomic level in Argentina. And you can see the date of this study. It's a pretty old study, but it's really interesting. They looked at immune complexes with the adenovirus hexon on the surface of the virion, as well as serum cytokines. Now, back in 1994, this was a tough study to do, but and group 1 is a moderately affected. Group 2 are those who had severe disease, and group 3 were those who had severe and ultimately fatal disease. And you can see that those with worse disease, who were sicker, had a higher likelihood of having identifiable IL-6 in their serum, and IL-8 to some extent, and also TNF alpha. They also had a fair number of individuals who had IgM antibodies present that bound adenovirus hexons. The same with IgG, the same holds for that. But I point out that IL-6 and to some extent TNF alpha may be playing a role in the ultimate development of PIBO in these patients. Well, how do we diagnose bronchiolitis obliterans? History is the key, I believe, and I teach a course to my second year medical students about the importance of getting a good history. If you have a patient, these are for these older patients, you want to ask about their previous history. If they have had a severe respiratory infection, a lower respiratory tract infection, especially a lower respiratory tract infection with adenovirus. Obviously, if they've had a history of a lung or stem cell transplant, that's an easy factor. But digging in and finding out previous histories of severe disease may be helpful. You have to have an index of suspicion, I think, to diagnose some of these patients. The asthmatic patient who has fixed airway obstruction and doesn't respond to bronchodilators, at least you should go back and look at their history to see if they have risk factors for bronchiolitis obliterans. The lung recipient whose FEV1 has declined by 10 to 20% from baseline is at risk for the development of bronchiolitis obliterans syndrome. Now, bronchoscopy, BAL, and transbronchial biopsies are common in my lung recipients, and that's a first step to rule out infection and acute cellular rejection. But as I mentioned earlier, it is not very good at diagnosing bronchiolitis obliterans pathologically. So as a matter of fact, you're more likely to miss the lesions than get the lesions on a transbronchial biopsy, simply because they're too small. If you are to get lung biopsies in these patients, I think, and this is my opinion, that it should be with an open lung or transthoracic biopsy, preferably of 2 sites, so you'll get good tissue samples. However, getting a chest high resolution CT scan with ventilation held at total lung capacity and FRC, I think is very useful. PFTs with lung volumes are also useful. At our institution, we do infant PFTs, and I'll show you an example of how useful this can be. Although, as you'll also see, it may not be useful enough, believe it or not. But I think I strongly recommend that if you can get infant PFTs, that you try and get them. Lung biopsy remains the gold standard. That's the way we have to diagnose it sometimes. However, with an appropriate history, such as a documented lower respiratory tract infection with adenovirus that was a long-lasting infection, led to severe disease with respiratory failure, requiring mechanical ventilation, that coupled with a high-resolution CT scan showing what I'll show you as mosaic perfusion, probably has a very high specificity for diagnosis and sensitivity for diagnosing PIBO, post-infectious bronchiolitis obliterans. More than that, if you have PFTs that show fixed obstruction, an increased RV-TLC on lung volumes, plus a high-resolution CT scan with mosaic attenuation, that's probably acceptable as being diagnostic, avoiding biopsy altogether. Biopsy should be your last resort, not your first resort. But this is going to depend on your own institution, what you have available to you. But if you can get infant PFTs in these babies, I strongly recommend it. This is the information I have from an 11-month-old boy. It was 11 months when this study was done. This was 3 months following a severe RSV and adenoviral combined respiratory tract infection leading to respiratory failure and a need for mechanical ventilation. He was in the hospital for over a month. So this was taken only 3 months later. And that's what I want to stress to you. This is 3 months later after this serious infection. And as you can see, his FEV 0.5, you don't use an FEV1, but FEV 0.5 was 5, almost 6 standard deviations below the mean expected for his age. This boy is severely obstructed. And following bronchodilator, if anything, he loses volume. Likewise, his residual volume is 283% of the predicted normal, with an RV-TLC ratio that is 223% of predicted. The CT scan was obtained at the same time as we did the infant PFTs. We do our infant PFTs under sedation. We reserve a spot in the CT scanner. After the study is done, the patient is wheeled into the scanner, and using the same technique, which is held ventilation, we can get CT scans at total lung capacity and FRC. And as you can see with the double arrows here on the right side here, there's an area of it's more white, there's less attenuation. And here there's hyperinflation on the left here, left side. This is the patient's right, obviously, that is shown here. And I could have taken a whole bunch of other slices from this particular CT scan, and they would look very similar with areas of hyperinflation and areas of increased density, consistent with mosaic attenuation. How do we diagnose bronchiolitis obliterans post-lung transplant? Briefly, it has to do with because it's so hard to diagnose it by transbronchial biopsy, that's led to the concept of the bronchiolitis obliterans syndrome, which is PFT based, with a drop in their FEV1 below their baseline, a stable baseline following transplantation. And multiple factors, by the way, have been associated with the development of bronchiolitis obliterans following lung transplantation. And I think what many of these have in common is the potential for damage to the airway epithelium. Now, I say that, or a lot of people think that bronchiolitis obliterans is probably the common denominator of a way of healing, but whether the cytokines that are released following lung transplant or stem cell transplant in the airway are identical to those released following a viral infection is not really known. We make assumptions that they may be similar, but I don't think we know for sure that the timing of those cytokine releases or whatever those the cells that have to come into the airways, whether those are identical in patients following lung transplant, stem cell transplant, and following, say, an adenovirus infection. I don't know if they are identical. So a lot of the stuff we use, so some of the medications we use to treat PIBO are those based on those having been used in lung recipients, and that may or may not be correct. So we're going to go right to treatment of bronchiolitis obliterans. Let's get first the overview. Treatment data in post-infectious bronchiolitis obliterans is limited at best. There are no accepted protocols that are in existence that have been studied carefully. As I said, many of those therapies are extrapolated from BMT or lung transplant, and the clinical course in PIBO is quite variable, so it's not even clear whether we're sure the treatments we use are helping. Good supportive therapy is the main priority for treatment and care of these patients, I believe, while we're still looking for better therapy. Anti-inflammatory therapies often are employed, but as you will see, They have not been fully studied. And I think you need to keep that in mind when you see these patients. As I like to say, having multiple choices of therapy for any entity often means that none of them work well. Because if something worked really well, you'd only need one form of therapy, right? But that's not the case in PIBO. Anecdotal treatments are the norm, especially for post-infectious bronchiolitis obliterans. There have been no randomized controlled trials of treatments for post-infectious bronchiolitis obliterans. There are a few trials of treatment for bronchiolitis obliterans from other causes. None are large, few are randomized, and almost none of them are well controlled. And I'll show you examples of that in a few minutes. Well, what do we have? Well, there's fluticasone, azithromycin, and montelukast. Inhaled fluticasone, oral azithromycin three times weekly, and daily montelukast. This was based on a retrospective study of a stem cell related BO that showed some steroid sparing. An open label prospective study suggested some improvement in FEV1 3 months after treatment, but there have been no large studies of this FAM therapy, so-called. The advantage of it is it's relatively safe. I would say that I'll use the word relative. The inhaled steroids probably are a little bit safer than systemic steroids. Azithromycin, as many of you are aware, has recently been studied in a randomized trial following stem cell transplant. And it was actually, this trial was stopped because those who received the drug had a higher risk of relapse if they had a pre-existing hematologic disorder, such as leukemia. So one should be careful about just handing people azithromycin. I still do it, but I make sure they don't have a previous, say, malignancy, blood malignancy. Steroids by pulse, with or without intravenous immunoglobulin, is a common treatment. I learned about this years ago, and the source for this, I was told, dates back to a single sentence in a textbook of pediatrics, which I can't find, or maybe a pediatric pulmonology, which I still have been trying to find, which alludes to its use in patients with inflammatory diseases of the lower airways. It has not been studied well. There is one study showing tiotropium may be useful as a bronchodilator, but it certainly doesn't cure the disease. But I give this to some of my patients who are having dyspnea, and this is with established bronchiolitis obliterans, and it may actually be useful clinically. There are a wealth of biologics that have been touted. I already mentioned TNF alpha may be elevated in those patients with adenovirus early, but I don't know whether that is always the case later in their serum. There's other studies that have shown that many of the cytokines are still elevated in patients with long-standing bronchiolitis obliterans, but it doesn't mean that they're still having the changes secondary to those particular cytokines at that time. But TNF alpha inhibitors, tocilizumab, an anti-IL-6 receptor antagonist, pirfenidone, and IL-17 inhibitors have been touted, but none have been studied fully. And we don't know either how we should use them or when we should use them. Extracorporeal photopheresis requires an infrastructure. Our dermatologic colleagues usually have this available, but it's very invasive and time-consuming. Very small numbers of patients have been studied, and none that I know of with post-infectious bronchiolitis obliterans in a randomized controlled fashion to tell me that this is an effective therapy. I know some of my colleagues around the country here do suggest its use, but there's very little data to support it, I believe. Let's talk about corticosteroids. It's the most commonly used anti-inflammatory therapy, but it's a risk factor. I mean, you can read some articles on it. Pulse steroids are used to spare side effects, but they're high dose and there are side effects of that. You want to give it before there's fibrosis established, because this is to stop the ongoing inflammatory response if possible. So if you're going to use it, I suggest trying to use it early and try to avoid chronic use by perhaps giving pulse steroids, but there are side effects of this. Now, there are some studies of corticosteroids in post-infectious bronchiolitis obliterans. Notice these are, over the years, are small numbers, as you can see, without controls and without placebos. So these are not randomized controlled studies, and they say effective or improved, but there's not a lot of data showing a definitive curative effect of corticosteroids. These studies also don't make it clear when these patients were given these drugs at all compared to when they had their first symptoms. And that may be one of the problems with this use of corticosteroids. How about monthly IV pulse methylprednisolone plus IVIG? Well, a lot of us do that. But as I said, there's no RCT that demonstrates its effectiveness. And what should we consider effective for treatment like this? Is it improved lung function? Is it a slower loss of lung function? If you're going to do that, I would offer that you probably ought to measure the lung function. And all too often, these patients are put on these drugs without following, especially if they're young infants, without measuring their lung function on a regular basis. Both methylprednisolone IV and IVIG have side effects. And because I've used it, I can say I've seen those and have to deal with them. The duration of that therapy is not agreed upon. Once started, it is not always easy to stop. I was referred a patient for a lung transplant who was a teenage boy who'd been on methylprednisolone by pulse and IVIG since early infancy. And he was now 10 years or more than 10 years into his therapy. And he came to me for a potential lung transplant. He did not need a lung transplant, but I didn't know if he should continue this. My feeling was he probably didn't have to continue this, but that was up to his referring physician. Determination of its effectiveness or lack of effectiveness is not actually always done in practice. So I think once you start down this road, you have to be prepared to give yourself an endpoint. How long are you going to treat your patient? How are you going to determine that they're better or not? And if they are better, how long will you then continue that therapy? And how do you judge that it's still being effective? I don't think any of these questions are answered for bronchiolitis obliterans following infections. I'm going to go back to this patient because he was only 3 months after his severe disease. I felt that I had a chance to treat him early. I thought this was a great chance to treat somebody early and to demonstrate that it was effective. So I tried to do that. I had to get permission from his insurance carrier here in the States to administer IV methylprednisolone at a high dose, you'll see in a second, and IVIG, both of which are, the IVIG is very, very expensive, you should know. And this is what we saw. We did baseline and monthly treatment with IV methylprednisolone. This was the dose, 10 milligrams per kilo for 3 days, and at the same 3-day stay in the hospital, by the way. He was hospitalized for this each time. He got 1 gram per kilo of IVIG for 2 days. That's felt to be an immunomodulatory dose. These were the baseline PFTs you just saw over here on the left. This light blue line at the top is his RV to TLC ratio. The darker blue line below it is the forced vital capacity, and the flow rates are shown below. We did three doses, and just prior to the 4th dose of IV methylprednisolone and IVIG, I repeated his PFTs, and to well, I was actually very happy to see this. His RV TLC ratio dropped. Notice it's still about 180% of predicted, but it's down from about 230. His FEC was up. His FEV 0.5 was slightly up, but notice it's still less than 100% of predicted. I then continued his IVIG and methylprednisolone therapies on a monthly basis. I got another study right here before he'd gotten month 9, or maybe this was right after he got his 9th month of therapy. So this is into this therapy, and as you can see, his RV-TLC has not gone down. If anything, it's gone up. His FEC has not continued to stay high. It's now slightly lower. His FEV 0.5 is not maintained there. It's a little bit lower. His flow rates really aren't changed. I then stopped it. I had agreed with his insurance company that if it wasn't continuing to show improvement, I would stop and retest it. And I did that 6 months later. And as you can see, there's not much, there's not a lot of change here. So this suggests to me that even though I started this at a time that I thought was very, very early, it was not fully effective in either reversing his changes, his airway changes, or his flow rates. As you can imagine, that made me unhappy. But at least I proved to myself, at least with this one patient, that continuing this therapy maybe was not warranted beyond this point. We need more trials like this. This is a trial of one patient. We need many patients to show us what the correct timing for this type of therapy is relative to the onset of disease, and how long it should be given, because I don't think I know the answer. Supportive care therapy for these patients, therefore, remains the key. These kids often need oxygenation. Some of them continue to require non-invasive ventilation or even regular ventilation. Nutritional support, avoiding exposure to smoking, making sure they get their immunizations down the road as they get older, avoiding aspiration events, and if necessary, studying them for their swallowing function. If they develop bronchiectasis, be prepared to monitor their sputum, teach the families how to do therapy, manual chest physiotherapy, or if necessary, try to get a vest that we use for CF. Bronchodilators, if responsive to them, especially I would suggest trying tiotropium in the older patients, and doing pulmonary rehab as needed. Finally, if they're still very, very severely ill, a referral for lung transplantation may be indicated. I will be honest, I've been referred several patients with post-infectious bronchiolitis obliterans for lung transplantation. The majority of them are too well to get lung transplant, to receive a lung transplant. In other words, the risk of death from the lung transplant is overshadowed or outweighed by the degree of disease they have. We have done one transplant on a single patient with a very severe post-infectious bronchiolitis obliterans. He developed his adenovirus infection at age 10 days and has been on oxygen. He was on oxygen for the next 8 years, including nocturnal non-invasive ventilation. He also carried a gene that is associated with a mutation in a gene associated with a ciliopathy, and has a family history of primary ciliary dyskinesia. So I think it's a combination that led us to carry out his transplant. But it's been very rare that I've had to transplant anyone with post-infectious bronchiolitis obliterans, at least in childhood. Now, some of these patients, as they age, may outgrow their lungs, if you will, and may require transplant. But if you can wait until they're older, you've saved them having a procedure early that has a half-life, where the half-life for lung transplant recipients in terms of graft survival is only about 5 years. So the longer you can wait, the safer your patients will be. So why don't we have effective treatment for bronchiolitis obliterans? Why is this not working? I thought I was doing a good job by starting my patient on IV methylprednisolone and IVIG only 3 months after his adenovirus infection. You can imagine my dismay that it wasn't that effective. Well, here's some possible explanation I can think of. But one is maybe we're not targeting the right molecular molecules. Maybe we don't know what we're looking for. I mean, we talked about all of these things. Maybe there are other inflammatory cytokines we should look for, or we need to find out when they're out there. And I'll tell you how I think we can approach this. But maybe the problem is that we're actually diagnosing bronchiolitis obliterans late, not early. Remember, bronchiolitis involves the small airways. It's called the silent part of the lung for several reasons, but one is that there are so many of them that you can have a lot of damage to the smaller airways before you are symptomatic. The pathology also is not uniform, and even the airways that are involved discontinuously. They're skip lesions. So it's difficult to diagnose. You need transbronchial biopsies sometimes, and you have to be in a place where you do the right type of CT scan and, if possible, the right kinds of pulmonary function testing. The pathology probably evolves quickly following a severe lower respiratory tract infection. And this, I think, leads to late recognition, and I'll show you some data that supports this. First of all, are we diagnosing bronchiolitis obliterans in time? Here's just 4 studies that looked at the age of onset of symptoms and the age of diagnosis of bronchiolitis obliterans. And you can see the lag time to diagnosis is measured in months, or in this case, years. This is 4 years from the time of symptoms to the time of diagnosis. This is 2 years from the symptom onset to the age of diagnosis, 6 years, et cetera. I think we are diagnosing this entity too late to really be able to offer effective therapy for an event that took place back here at the start of their symptoms. Remember, the viruses are usually gone. There is some data to suggest adenovirus may linger, but that's in a minority of patients. So I would offer that the damage is done early, and we have to be able to attack it early if we're going to get give ourselves a chance to help our patients as much as we would like. There's another paper that supports this. This is by the group in Buenos Aires. And as you can see, by the time these patients were diagnosed, they were first of all, they were able to do lung volumes, which meant they were older, and they probably were all sick in infancy. Their Z-scores of their FEC, as you can see, are quite similar to the patient I showed you of mine, with values that were far lower than you would expect. They're markedly air-trapped, and their RV-TLC, as shown by their RV-TLC ratio here. So I think we are diagnosing patients too late. I'll show you an example of why I think that also in a canine model of adenovirus pneumonia and bronchiolitis obliterans. This was done reported in 1985. These were beagles, small dogs that were young. They had a dog-specific adenovirus with which they were infected. As you can see, the viral amount was very high very early, and then they rapidly cleared the virus. They built up antibodies appropriately, and this is days post-inoculation. So I want you to look out here at the very end of this, where there's lots of antibodies present. The virus has been gone for like 2 weeks by the time they got to the end of the study. And here's some of the stuff that they found. 2 days post-infection, you can see the viral particles in a non-ciliated airway epithelial cell. By 5 days, these animals had lost cilia in their airway epithelium. But more importantly, I didn't give you all the data, but 26 days post-infection, this is a terminal bronchiole that should be this big, but all this is thick, dense connective tissue. This is another terminal bronchiole that is completely occluded. Notice the alveoli are pristine here. The alveoli are fine. This infection is gone, but this is already here. And this is only 3 weeks after the infection. This patient I studied was 3 months after his infection. So you might well imagine that, that his airways were also severely involved by that time. Well, with that sad note, sorry, what are the future directions for PIBO research that I can offer or suggest? First of all, I want to point out that there's much more to a viral infection than the virus alone. There's a host, and the host is in an environment. Recall that one of my earlier slides pointed out that the patients were from a lower socioeconomic, they had a lower socioeconomic situation, and there are things in that environment that may be different. But as we all have seen, and certainly I have, the environment doesn't seem to only involve, or this disease does not only involve those patients of a lower socioeconomic status. So we need to take a little step back. What's the problem? And the problem may be that the patient may have a genetic predisposition to develop a severe response to a particular virus. Then there's the virus itself. Maybe there are certain viruses that are shall we say, more pathogenic than others. There are gene sequences, as we are seeing with COVID right now. There are minor changes to the viral genome that render it more or less, say, infectious and possibly more or less dangerous. There are probably environmental factors, which we have learned in the COVID era are certainly at play, and also the I didn't put them, the environmental and socio-economic factors that are also a part of this triangle that lead to what the ultimate outcome will be. So there's a lot I think we need to learn about, say, PIBO, and specifically adenoviral PIBO, to help these patients and help us understand this disease better. I would suggest that we have animal models for lung transplant and stem cell transplant, but really good animal models for PIBO are lacking. We're not going to use dogs. A, they're very expensive, and B, we don't have the right reagents to study them. There's not a good mouse model, and I've talked with someone who does adenoviral infections in mice, and they don't develop PIBO, possibly because of the amount of adenovirus he's using per mouse, or because of other factors that would take a while to define. But we really need a good animal model that's reproducible and relatively inexpensive and fast to define treatment targets that we could use in humans and in human studies. We need to know the cytokines that are released by the cells and the timing of their appearance and their potential interactions. But we need to know the cells, the cellular mechanisms and their relation to cytokine production and interactions. There are going to be new imaging concepts that we can use. You can't follow serial CT scans in these patients. That's a lot of radiation. MRI scans use an ultra short echo time, can provide images that are very similar, almost equivalent to those of CT scans. And I think that down the next year or couple of years, we should have access to those potential treatment, potential monitoring devices, so we can avoid all the radiation in CT scans. And this, I think, is coming down the road. And I've given you a reference here under here. PFTs, we should add multiple breath washout. Lung clearance index is another measure. And there are some articles on this elsewhere. I don't have the references here. MicroRNAs or non-coding RNA that are involved in gene regulation, and I suspect there might be evidence that they are involved in some forms of bronchiolitis obliterans and cell and organ regeneration. RNA-seq is an indirect monitor of gene up or down regulation on a single cell basis that also could be useful. And I would suggest that these could be used in patients like this. We don't know anything, I think, about the microbiome and its role in immune surveillance in terms of the relationship to something like a post-infectious bronchiolitis obliterans. We're learning a lot more about the microbiome. It is involved in immune surveillance for sure, but how that relates to PIBO, I think, is still not known. For example, I put this here, the X's refer to patients. They have all been infected with adenovirus, and here's a patient here who has a very short stay. He gets better, he or she gets better, and they're out of the hospital. On the other hand, this patient very early on has to go to the ICU, gets intubated, and ultimately dies. This patient has a longer length of stay, but ultimately recovers completely. And this patient has a little bit later time to develop his respiratory failure, but survives. And this patient, about the same time, gets intubated and ultimately goes on to develop post-infectious bronchiolitis obliterans. What is different about all these patients? What separates them? What is it what is their cytokine response? What is the what is the adenovirus that infects them? What is different about them that leads to different outcomes from the same, quote, infection? So this might lead us to a prospective study of nasal, serum, and airway cytokines in patients like these to see what's different about them. We should do, we could get the adenovirus that infects each one of them and see what its genomic variation might be, and look at the DNA of those infants with adenoviral infections, both those who go on to develop bronchiolitis obliterans and those who do not. We could do that with their parents, for example. We could also do environmental surveys to find out what environmental factors might be at play. What's different about those who go on to develop severe disease? That would be really nice to know. There also sometimes should be prospective blinded studies of possible treatments of PIBO when identified early in its course. For example, we could use pulse steroids and IVIG as I did. We could use FAM as I also have used, but I think we should use infant PFTs as an endpoint. So we should start with infant PFTs as early as possible. I did my infant PFT on that patient I showed you 3 months. Maybe I should have done it even earlier. Maybe I should have tried to do it while he was soon after he got off the ventilator. And by the way, there are ways of measuring pulmonary function testing, not lung volumes, but pulmonary function in intubated patients that we do here. But those are things to think about. Any studies like this would obviously have to be multi-center in nature and probably international in nature. They would require careful planning and organization, and they would be very expensive. But I think if we're going to solve the problem, it would be nice to have either the animal model that would guide us, or then a subsequent, maybe a more targeted prospective study based on a good animal model. Obviously, this is a lot to ask and a lot to do, but I think that that's where we have to go. I was told by my mentor back in the day that sometimes you have to be like a turtle. Sometimes you have to be like a turtle. And what do I mean by that is not by going into your shell and hiding, but look at this turtle here. It's walking here. And the only way a turtle makes progress is when it sticks its neck out. And for those of you who don't know what sticks your neck out, I mean, you have to take some risks in order to do things and make progress. And I think this is one area in which sticking our necks out and deciding to do difficult research projects is appropriate. But obviously it will take some planning and time. But those are just my thoughts. I think the whole problem of PIBO probably relates to our timing and our understanding. And as we improve both those, identifying these patients earlier and trying to get help to them earlier, we may have more progress in that regard. And with that, I'm going to stop here. If you want these slides, I know you're recording this, but if Yasmin, for example, wants my slides, I would be happy to send them to her, and she can share them with you. And I can hang out for a little bit and answer what questions you might have. Thanks a lot.